Welcome to the Brief Action Planning, Helping People Take Active Roles in Their Health and Wellness webinar. We're glad you're here today. My name is Tanya, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is co-sponsored by ourselves, CIRPD, and Pain BC, and in collaboration with the Canadian Pain Coalition. It's also made possible through the support of the Direct Access Program through the BC government. And as I mentioned, my name is Tanya, and I'll be moderating the webinar and handling the question and answer session today. And our presenter is Connie Davis. Connie is a nurse practitioner specializing in care of the elderly, and she's also the program director of the nonprofit Center for Collaboration, Motivation, and Innovation. CCMI provides expertise in a stepped care approach to self-management support, including training healthcare professionals, reaching out to the public, and designing patient-centered care systems. Connie is a trainer of master educators for the Stanford Chronic Disease Self-Management Program. She's a member of the Motivational Interviewing Network of Trainers and adjunct clinical faculty for the University of British Columbia School of Nursing. So I will go ahead and hand it over to Connie for her presentation.
Thanks so much, Tanya. I really appreciate it. And thank you, everyone, for joining us today. Looking forward to the discussion as we move along. So let's just go ahead and get started. As you know, one of the first things we often talk about when we're giving a presentation is what are our objectives. So here are some goals for this hour that we'll be spending together. And the first one is it's often helpful to get on the same page, so have shared definitions. So we'll talk about a definition for self-management support. And we're going to go over an approach called brief action planning. So we'll talk about how that fits with self-management support and what the evidence is for action planning in general. And also make sure you know how you could learn a little bit more about brief action planning, self-management support, and the stepped care approach to self-management support. And please do use the chat box as we go along. Looking forward to responding to questions towards the end of the talk or sometimes as they apply. So here's the definition of self-management, and this is from Barlow and colleagues. This has been around for quite a while, but this definition has stood the test of time. It still really speaks to a lot of us who work in this field. So Barlow and colleagues wrote that self-management is the individual's ability to manage the symptoms, treatment, physical and social consequences, and lifestyle changes inherent in living with a chronic condition. So if we wanted to kind of deconstruct that definition a little bit, chronic condition, so meaning anything that's of an ongoing nature, as opposed to an acute condition, which generally is fairly rapidly diagnosed and treated and often has a cure. So an ongoing condition like arthritis, some back pains become chronic, diabetes, heart disease, high blood pressure, glaucoma, lots of things are ongoing or chronic conditions. And Barlow, in this definition, also relies on some research that came out of the work of Strauss and Glaser and Corbin, back where they interviewed people with chronic conditions and found out what tasks they faced. And so they said that they needed to learn how to manage the illness, they needed to learn how to manage their life, and they also said they needed to learn how to manage emotions. So this definition kind of touches on at least some aspects of that. So abilities to manage. Another thing that I like about this definition is that it's actually neutral. Self-management is how people manage, and some people are self-managing in a way that's more likely to lead to better outcomes, and some people self-management in a way that it's maybe harder for them to reach their goals or outcomes. So that's the definition of self-management. Here's the definition of self-management support. Now this is from a physician, Tom Bodenheimer, who's a family practice physician and who's worked a lot in systems and trying to understand system redesign and mostly how we can help patients or clients or people we serve to live healthier lives. And so he wrote that self-management support is the assistance that caregivers give patients and their self-defined circle of support so patients can manage their conditions on a day-to-day basis and develop the confidence to sustain healthy behaviors for a lifetime. Now, since he's a physician, he uses the word patient. You may use the word client, or you may be in a peer relationship, or it may be a friend or a family member you're caring for. So it's the assistance that caregivers give other people and their self-defined circle of support. So that's an important notion here, that people identify their own supporters. Sometimes it's their family of origin, sometimes it's friends or neighbors or colleagues or coworkers. And he talks about helping people manage conditions on a day-to-day basis. And then he says something really important, that the goal is for people to develop confidence to sustain healthy behaviors for a lifetime. So that's really key. Behavior is part of the picture, but confidence is a really big part of the picture. So that's the definition for self-management support. Now, there's another term that has been used often in this field, and many of you may be familiar with programs that are self-management education. So self-management education, it can be defined as programs that are based on patient-perceived problems and address the 3 self-management tasks that I mentioned before. So medical or behavioral management, so the things you need to do to manage the illness, role management, which is how you have your daily life with that overlay of the chronic or ongoing condition, and emotional management, how you manage the feelings that come up now that there's a chronic condition in the picture. So this self-management education builds skills in problem solving, decision making, taking action, forming a patient healthcare provider partnership, and using resources. And these skills can be applied to any chronic condition. Now, this definition is drawn from a wonderful article by Kate Lorig and Hal Holman, who were 2 of the people that developed the self-management chronic disease program out of Stanford Patient Education Research Center down in California. And so self-management education, key things to remember from this definition. Self-management education addresses what patients see as important. It addresses those 3 self-management tasks, and it builds some certain skills: problem-solving skills, decision-making skills, taking action, forming relationships, and using resources. So important things to consider. So let's get all of our definitions out of the way. Something else that we often have available in healthcare systems is condition-specific self-management education. So if you have a diabetes education program, or if you have a lung disease education program or a heart disease program, those are examples of condition-specific self-management education. So you could define that as the facts and technical skills about a particular disease, risk factor, symptom, or condition, such as disease-specific knowledge, monitoring, and treatments, and their risks and benefits. So self-management education is generic. It's skills about action planning, problem solving, working with healthcare professionals, etc. Condition-specific self-management education is going to talk about the specific diagnosis, the treatment, how the body works, those kinds of things. Now, these things all work well together. So self-management education, which an excellent example are things like the arthritis self-help program, the chronic disease self-management program, positive living, which is a program for people with HIV/AIDS. Those are self-management education, generic skills. And so within those programs, or in addition to those programs, you could also have condition-specific skills and information that would be very helpful. And some people have more than one condition, so they may be attending more than one condition-specific skills and information, or need that in more than one case. So there's lots of different specifics that can exist within that whole realm of self-management education. And then around all of that is this broader help that's called self-management support. Okay? So that's just one way of trying to think about how these different things, self-management support, self-management education, and the condition-specific education can work well together. We have that general theme of self-management support. We have the skills that can be transmitted through self-management education programs or individual relationships, and there's condition-specific skills and information that are also useful. Now, one of the things we always want to be careful about is thinking about whether or not what we do is effective. And so for most of us, we turn to the evidence for that, and we talk about evidence-based or evidence-informed practice. And so one of the things that's really interesting about self-management support is that the literature and the evidence has been growing immensely in the last 10 or 15 years. Self-management support as a term really became popularized in the late 1990s when the chronic care model was published, and that term started to appear more and more in the literature. And recently, it's about 3 years ago now, De Silva and colleagues actually looked at different self-management references. And this was a very large review that they did for the Health Foundation in the UK. And I'll let you review that quote there by De Silva. They actually identified 562 different self-management references and studies. And their conclusion that was written in the introduction to their report is that the literature shows that proactive, behaviorally focused self-management support that's designed to increase self-efficacy, there's that self-confidence again, can have a positive impact on people's clinical symptoms, attitudes and behaviors, their quality of life, and their patterns of healthcare resource use. This quote really captures why people have been so interested in self-management support. There's evidence that it works, and it works to impact people's symptoms, their attitudes, the changes they make in their lifestyle, the quality of their lives, and also how people use healthcare. So that's gotten a lot of people's attention. Now, this is a very lengthy report, and I wanted to show you a diagram from the report that I think is very interesting and very helpful. So one of the things that De Silva and colleagues did when they were reading and reviewing the literature in self-management support is they really tried to understand the different kinds of strategies that were used in the self-management support programs. So you'll see there's an arrow going up and down in the middle of the slide, and it's a focus on self-efficacy on the top of the arrow and a focus on technical skills at the bottom of the arrow. So they saw that as kind of a continuum where some of the self-management support programs that they saw were really focused technically. Those are most likely in the condition-specific self-management education realm. And there are those that focus on self-efficacy or self-confidence and building people's ability and their confidence in their ability to make changes in their life. Now, the other continuum that's mapped here on this diagram goes from the left to the right. And so that's whether or not the intervention focused on information provision, which you see there on the left, or behavior change, helping people make changes in their life, which is on the right. And then what they did when they reviewed the studies is they kind of put points on this table, this 4x4 diagram, to show where programs kind of landed, whether or not they were more technically and information-oriented. So that's more of your patient education or your self-management education that might be condition-specific. So you see the bullets there, written information, which is necessary but not sufficient, falls in that category. Electronic information, people who access the internet, and online courses are examples of those that are heavier on the information provision and focus on technical skills. We'll just go around this diagram. So looking at those that have information provision and focus on self-efficacy, examples of that are interventions that are patient-held records, where people carry their own information with them. Making care plans together falls into that category, both information and focus on building people's confidence. They hold the information. It's theirs. Continuing around the circle, the programs and self-management support articles that they reviewed that focus on both self-efficacy or building confidence and on helping people make behavior changes are documented here. So closer to the middle, you'll see active group education. Once again, those self-management education programs, like the chronic disease self-management programs out of Stanford, are examples of this. They provide behavior change support and focus on building people's confidence. Telephone coaching, very popular intervention being used now, which focuses on both of those things as well, helping people make behavior change and building their confidence. Goal setting, solidly in this camp. And then you'll see motivational interviewing up there in the corner, which is very strongly oriented towards behavior change and building self-confidence or self-efficacy. Continuing with the last quadrant of this diagram, efforts that focus on both technical skills and behavior change would be a lot of the group education. Diabetes classes are a prime example, where people learn how to monitor their blood sugar, for example. Different aspects that might be more familiar are people learning exercise programs in a group to manage maybe their pain. Self-monitoring is another example of this. So people who keep pain diaries or monitor their symptoms, their mood, those are examples that focus on a technical skill, monitoring, along with behavior change. So using that information to analyze whether or not changes are making a difference, that's where the behavior change comes in. So that's an example there of different ways you can think about the strategies to support self-management. Really useful when you think about all the different programs that are out there. I'm going to move along to the next slide here. Sorry, there's a bit of a delay right at this point in time. We'll get the next slide up for you. And then we'll just talk a little bit more about how the evidence for self-management support has been perceived. So one of the things that a group of us did back a few years ago now was to look at the literature for self-management support in a slightly different way than De Silva and colleagues did. We were reviewing the self-management support literature for principals. So this was led by my colleague Malcolm Battersby, who's in Australia. And so we were looking at what the effective programs were doing. And we came up with these 12 different principles. And so I'll just review those really quickly for you, too, and you could refer to that article if you're interested in more depth in what we found. Things that were really clear is that programs that were effective focused on targeted assessment. Healthcare professionals often like to do a lot of assessment. It's a very comfortable place for healthcare professionals. And to be efficient, targeting the assessment on things that matter to patients is what's really crucial here. It's pretty clear that information alone is not sufficient to change behavior for most folks. Some people, when they hear what they should do, simply go out and do it. And for a lot more people, it's more often a challenge to put it into daily practice. Sorry about that, just flipped out here. The third thing is a non-judgmental approach. This is really exemplified in motivational interviewing, that in having a non-confrontational, non-judgmental supportive style is really important in self-management support. Another principle is to set goals collaboratively. And also, problem solving is important as a collaborative practice. So helping people apply their problem-solving skills to their health. Another thing that's really clear is that a wide range of providers, and including peers, can be very helpful in self-management support. And principle 7 is the different settings. Setting doesn't seem to matter a lot. Community-based settings are very helpful for self-management support. Again, principle 8, that self-management, self-efficacy focus is very important. Providing active follow-up so that checking in on what's happening is really crucial for better outcomes. Number 10 refers to care management. So that's a way of stepping up care for people who need more support. The 11th one is about linking to effective community programs. And the 12th one is that interventions that seem to handle more than one aspect of care seem to be the most useful. So if you think back to the diagram from De Silva, thinking about the ones that focused on technical skills versus self-efficacy, or the ones that were focused more on behavior change, different aspects of that can really be helpful. So if you feel free to chat in if you have any questions about the things that I'm bringing up. One of the things I mentioned we would talk about is stepping up care for self-management support. Now, most of us have realized that when clinical conditions, especially chronic conditions, are managed, there's a way that we step up care. So if you think of somebody who maybe goes to their physician or their nurse practitioner and they're diagnosed with high blood pressure, and generally the first thing that the clinician asks them to do is to make some lifestyle changes. Maybe cutting back on salt intake or losing weight or exercising more frequently would be a common guidance at that point. So that would be the first step in addressing the high blood pressure. If the person comes back in and they've made some changes and the blood pressure is still high, the care gets stepped up. And then a medication would be the most likely next thing that would happen. And usually it's generally a low dose of one medication. Now, if the person takes that medication and the blood pressure is still high, the most likely thing that happens next is that another medication would be added. Could be another step might be to increase the dose, but more often now smaller doses of multiple drugs are being favored in the current practice. That, of course, may change. So the care gets stepped up. And so every monitoring helps us know whether or not it's working, and we step up care until we reach the desired effect. So a group of us have worked together and really thought about self-management support and whether or not you could conceptualize self-management support or picture it in the same way. So what you see in front of you is a diagram that does this. Now, this was published recently in a document from the Health Council of Canada. Some things to notice about this document is the self-management support is happening inside of the largest cube there, which is called healthy communities and supportive family, friends, and caregivers. So one of the things that we think about often in health are the social determinants of health. And the social determinants of health, their influence would be in this larger box. We know that having safe places to walk and adequate income, access to good food, all of those things, good education, are all very important in people's ability to self-manage. So there are things that we could do in those realms that really influence whether or not people will be able to self-manage their conditions well. Having supportive caregivers also is important. The next step, you'll see there's a foundation step there, is actually about some basic things that are really important to lots of people. And so that would be things like working across cultures and working in diversity, and working in health literacy and health literate ways so that people can actually understand the information that's given to them. And another thing that's really important there is addressing activation or engagement messages. So ways that we give people encouragement to actually be very involved in their health and in their health care. So if you can imagine the steps that are engaged, so we talked about the broader system that's out there, and then we have this foundation that's working across cultures, being able to provide information that's understandable, and also in activating. That's very important. Okay. The next step up is behavior change support. So that would be the things that are mentioned in those articles that we talked about before. So helping people set goals, doing action planning, doing problem solving, and providing follow-up. So lots of people can do just fine based on the basics. Some people need a little bit more support, so that would be the goal setting. And then some people need even a little bit more help than that. So in this particular way of thinking about things, we've labeled those advanced approaches. So things like motivational interviewing, using care management approaches, problem solving, shared medical appointments, things like that are very, very helpful. And at the very tippy top of this diagram are things that are expert approaches. And so for me as a nurse practitioner, I would often go to another colleague, probably somebody with a background in behavioral health, to help me when there are folks who really are struggling to manage their chronic conditions. So brief action planning is a way that we've developed to help people make plans that can help them address their health. And so it's built on the principles and practice of motivational interviewing. So we design brief action planning based on what is known about how people make healthy changes. And so it's a patient-centered approach. It's also it's very client-centered. It's very specific, and we relied on the research, so it's very evidence-informed. So we said that brief action planning was based on the principles and practices of motivational interviewing. So the next thing we need to know is what is motivational interviewing. So what I've provided for you there is one of the many definitions for motivational interviewing. And motivational interviewing is a conversational style to enhance people's own motivation for change. So there's lots of things that are contained in that definition. And so motivational interviewing is more like a way of being with somebody instead of thinking about it as an approach or techniques or something like that. So this slide tells you a little bit more about the evidence for what's been found to be really helpful in motivational interviewing. And so the motivational interviewing, some of you may have been trained in this approach in the past or this way of being with people in the past. And one thing that happened last year is a brand new edition of motivational interviewing came out. And this edition of motivational interviewing actually has been significantly rewritten, and it also draws on the current evidence for what's working in motivational interviewing. There's been over 200 randomized controlled trials of motivational interviewing in different aspects of health, in addictions, in corrections. Motivational interviewing is broadly used. And there's a couple of things that are actually found to be really helpful with motivational interviewing. And one of them is that the spirit of motivational interviewing is very important. And so I'll talk a little bit more about the spirit of motivational interviewing in just a moment. Another thing that's been found to be very important is that people who are helping others can learn to listen for when people are talking about change and help them talk about change more. There seems to be a pretty strong link between when people talk about change, when they actually make a change, and how successful they are at making changes. So those are two things that are found to be very important. So when you hear talking about change, being able to give people positive feedback on that and helping to move forward and offer hope to people are very important techniques. So the literature is pretty clear that those things are important. The literature also tells us a little bit about what things don't seem to work in motivational interviewing. So some of the things that don't seem to work in these kinds of helping people change approaches are if you're very inflexible in your approach. And the way this was learned is if you have something that's too scripted and clinicians are not listening or getting cues from the people they're working with, that can actually be not helpful. And so having inflexible, too scripted approaches can really not be helpful. And another thing that's not helpful is when people are ready to move on and make plans, if you're not ready to go with them, that makes a difference too. So those are some things, a little bit from the research evidence that can be found to be helpful and not helpful in motivational interviewing. So the spirit of motivational interviewing is the foundation for brief action planning, and also one of the things we talked about is very important in what seems to be effective. And so some notions that are in that are, we've actually used this acronym of CAPE. So you see that there's 4 words: compassion, acceptance, partnership, and evocation. So what exactly do I mean by those things? Okay, so compassion means that when we're working with somebody in this style, we take their best interest into account. We're really focused on what's in the best interest of the other person. The A stands for acceptance. And so a lot of that acceptance is acceptance of people's autonomy, or how they're right to make choices and supporting their options. And also within that acceptance is also being able to demonstrate empathy and also be able to give affirmations or recognizing positive outcomes. The third part of this is partnership. And partnership is a reminder that there are many different kinds of expertise. And a person's expertise in their own life and their values and their own habits is just as crucial as any helper, especially a healthcare professional's expertise. So when we're working with people this way, we're equals, we're partners. The E stands for evocation, and that just means drawing forth. That when we're helping people make action plans, we draw forth from them what their motivations are for change. And the ideas are going to come from them, and less talking should come from us.
Okay, it's up.
So what we've done in brief action planning, and I should mention that brief action planning was developed by a group of people, Dr. Stephen Cole, who's a psychiatrist, Dr. Tamar Gutnick, an internal medicine physician, Dr. Kathy Rhymes, a family practice doctor, and myself. And we had a recent publication on this that you see there at the bottom of the slide. Brief action planning is a way that we develop to help people make action plans based on the best evidence out there about making successful change. So when you see this diagram, you'll notice that it's a flow chart. And we just talked about how you shouldn't be prescriptive. So this is a guideline, some guidance about how to have a conversation about taking something big, a bigger goal, and breaking it down into smaller steps. Okay? So there's blue on this diagram, and those blue rectangles represent 3 questions that kind of guide us in brief action planning. There's green, and green stands for go. Those are skills that are most often used in brief action planning. Yellow is a hint that there are things that come and go in brief action planning that you may or may not use, depending on what the person you're working with says. And then there's orange, which are tips, so that you can remember the spirit of motivational interviewing while making a brief action plan. So let me just talk you through this from top to bottom. So let's say you're in a conversation with a peer or a friend or a family member or a patient or a client, and it's looking like they want to make a change. So brief action planning would recommend that you ask a question, something like, is there anything you'd like to do for your health in the next week or 2? And that's a very specific way of asking the question. It's technically a closed question, but it's very an invitation to that conversation. And what you'll find is that people will respond typically in about 3 ways, represented by the yellow boxes below. They may have an idea, in which case you're ready to continue on making an action plan. They may be not sure what you're asking about. They may not be familiar with action planning, or they have a lot of different ideas and they don't know where to start. Those could be things that might happen there. If that's the case, you're going to use a technique called a behavioral menu. We'll talk about that in just a minute. Or their response may be, no, not right now. I'm really not thinking about making a change right now. In which case, you want to know if it's okay to check next time to see if they might be interested in making a change. So let's look at that behavioral menu. So if a person you're working with doesn't have an idea, there's a way that can be helpful in helping somebody come up with ideas of their own. So you can see there's 3 steps to this process. And because we're concerned about respecting people's autonomy, that was our acceptance part of our spirit of motivational interviewing, a good first step is to ask permission. So one way to say that is it okay if I share some ideas with you from other people who are working on something similar? All right? So respecting their autonomy. Once again, if they say no, then no, you're not going to do that. If they say yes, they're interested, there's some recommendations about how to share your ideas. So if they say yes, they want ideas, the recommendation is to share 2, maybe 3 ideas very briefly and not too detailed all together in a list. I'll tell you why that's important in just a minute. After you've shared your ideas in your list, the next thing to do is to find out if this is help them come up with any ideas of their own. Maybe one of these ideas would be of interest to you, or maybe you've thought of something else while we've been talking, okay? So a behavioral menu for someone who's interested in losing weight, for example, might go something like this. Is it okay if I share some ideas from other people I've worked with who are interested in losing weight? If they say yes, you might say, well, some people decide they're going to look a little closer at their eating habits, and other people decide they want to get some more physical activity, maybe even something as simple as walking. Would one of those ideas work for you, or maybe there's something else that you've thought of while we've been talking? Okay. That last bit where you're asking for ideas, that's getting back to that spirit of motivational interviewing, evoking, remembering that the best ideas are going to come from the person we're working with. Okay. So let's talk a little bit more about those 2 or 3 varied ideas briefly and all in a list. If the ideas are too specific, they're unlikely to fit for the person you're working with. For the example of weight loss, I chose ideas that were both about eating and about physical activity. So there needs to be some variety there. They can't all be programs or something that involves being with other people. There needs to be some variety. And they're shared all together in a list because the point is not to come up with the specific idea. The point is to try to get the juices flowing and the ideas going. Okay. So once the person has an idea, the next step, which is in the green box that says Smart Behavioral Plan, the next task is to see if the person is interested in getting more specific about the plan. Now, the literature is pretty clear that plans that are more specific, more short-term, like 1 to 2 weeks, are the best kinds of plans. But because we want to respect people, we are going to ask permission. Would it be useful to get a little more specific about your plan? Lots of people find that useful. And then the questions you want to answer are questions like what, when, where, how long, and how much, and when a start date could happen. All right? I'm going to tell you a little bit more about the evidence in just a minute. Let's just follow down on the flow chart. So once the person's got specific in their plan, the next thing to do is called elicit a commitment statement. And we'll talk more about that in just a minute as well. That's a way of having the person say their plan out loud. Getting to the blue box, how confident or how sure are you about carrying out your plan? That's about self-efficacy. We'll talk more about that in a minute also. For people whose confidence is pretty high, you move on to the next step. So if confidence is greater than 7, the next question, the third question in blue there, would it be helpful to set up a check on how things are going with your plan? And following down to the bottom, the green square is checking on progress. Okay? If people aren't confident, then we're going to use a technique called problem solving. So skill number 2. See, we were talking about the fact that it seems to be very helpful for people to be specific about their plan, we found that the best way to do this is to really think like a reporter and ask people questions. What, when, where, how often, how long, or how much, depending on if it's a physical thing or an eating thing or a relaxation thing. The measure might be a little different, and a start date. So for the example we were following along, maybe somebody decided that they wanted to do some back exercises that they'd been taught. So you might ask a little bit more about what is it? Well, it's the back exercises the physiotherapist taught to me. When would you do that? Well, I find it's most helpful to do that early in the morning after I get up, kind of loosen up a little bit. Where would you do that? Well, I'd probably do it in my home. And how long would that take you? Well, it's about 15 minutes of a routine. How often would you do that? Well, I'd like to do that at least 5 days a week on the days before I go to work. And when would you like to start? Well, I think I'm going to start tomorrow. So that's an example of answering those questions. There's some references that appear at the bottom of your slide there. And those are references actually from education and learning literature about the need to be specific and about setting goals. So eliciting the commitment statement. After the person makes their plan, many of us would be tempted to summarize that plan back to them. There's actually a way that in some research has been shown to be more effective, and that's having the person you're working with actually say the plan back to you. Okay? And the way we most often do this in brief action planning is to say, would you just say your whole plan back to me so I'm sure that we're on the same page, okay? And then have the person say that plan back. Now, the research here on the bottom of your slide is referring to the strength of the commitment statement. It's been found that when people say something out loud, the language they use actually is a fairly good predictor of whether or not they'll be successful on the plan. And people also have a tendency to be very consistent between what they say out loud and what they do. We have this kind of internal consistency drive that most of us want to adhere to promises we've stated out loud. So that's why the commitment statement is part of brief action planning. And on the next slide, it refers to that step about problem solving. All right? So problem solving is used when people's confidence or how sure they are they can complete their plan is low. And if you're using a number scale, the number is recommended to use is 7, and that's based on lots of different literature and a bit of a puzzling thing to understand. But it turns out that when people are confident, they're more likely to complete their plan. And if you've been able to complete a plan, that builds your confidence, which builds your self-efficacy. So on the next slide, this refers a little bit to that whole self-efficacy or self-confidence notion. Way back at the beginning of our discussion today, we talked about the research that showed that self-efficacy is an important thing to focus on when helping people self-manage. And this all comes from the work of Albert Bandura, who was a psychologist who studied how people make change. And it turns out that people's beliefs about their capabilities is an important predictor of lots of things, how they think about things, how they are motivated to change, and actually how they change. It's linked to healthcare utilization. So we want to build people's confidence. This is the key of brief action planning, is making the action plan small enough that people can be successful in completing their plans. That people will feel that feeling you get when you know you've set out to do a task and you've done it. And so that's what it's about. So in the action planning, we check confidence so that we make sure that we're building a plan that people are more likely to be able to complete. The next slide is a very brief overview about different ways that we can increase self-efficacy. And this is based on the work of Bandura, but in a really wonderful article that Lorigan Holman wrote in 2003. And the main way that people build their self-efficacy is through skills mastery, which is what action planning is all about. When we learn a new skill and we're able to do it, that builds our confidence. Another way you can actually build self-efficacy is through modeling. So when people see someone like them able to do the thing they want to do, that's very powerful in helping build people's confidence. And that's one of the reasons why group interactions are so powerful. Another thing that actually builds self-efficacy is reinterpreting symptoms. And so that's when we use our head, kind of a cognitive technique, to think about what's happening with us And instead of assuming that the symptom means, like, for example, that we shouldn't move, that's actually a signal that we need to move more. So reinterpreting symptoms is a powerful way to increase self-efficacy. And the fourth way is what's called social persuasion. And that's that gentle pressure that making an action plan with another person or working in a group, that gentle pressure and support that actually helps people make behavior change. So those are some ways to increase self-efficacy. Now on the next slide, you'll see the things that we do if self-efficacy is low. So if people's confidence in their ability to complete their plan is low, we use a skill called problem solving. So the way we recommend that you do this is give people some positive feedback. No matter what number they chose, unless it's 0, there's a number that's lower than that. So let's say, for example, our person making a plan to do their back exercises, when they ask how confident are you that you can do your back exercises 5 days a week on a scale of 0 to 10, 0 being not sure at all and 10 being totally sure. If the person said 5, your response would be something like, 5's higher than 0. That's good. We do know that when people's confidence level is a little bit higher, like above 7, they're more likely to be able to complete their plan. Do you have any ideas about what might raise your confidence? Okay. You can see in the flowchart there, if they have ideas, they might have realized it's a little bit too ambitious of a plan, or maybe they realized that next week is not a good week to start. They might adjust their plan. If they don't have ideas, you have a skill you can use, and that's the behavioral menu, asking permission to share ideas. Ideas are generally to cut back the plan, build in a support, or maybe start at a smaller step, or any other ideas of their own. As the last part of problem solving is to assure that that has raised their confidence up above 7 or more, or a higher level of confidence, after they restate their plan. The next slide goes on to another skill in brief action planning, which is checking in. Now this is another evidence-based skill. We know that checking in builds people's confidence, that the way human beings learn is we try things and some things work and some things don't. And if we don't pause and pay attention at that moment in time, our learning is less. So checking in is really important. Now, if you're a healthcare professional or a peer or a coach working with somebody, the checking in is often with you to begin with and fairly frequent. And as people get more familiar with making action plans, the frequency can back off. Another thing that's really important about checking in is the checking in doesn't have to be with you. The person can check in with a support person in their environment, or they can check in with themselves, like write themselves a message or text themselves or email themselves or put it on their calendar. So there's lots of different ways for people to check in. All right. So that's a very fast review of the different skills in brief action planning. And the next slide is just a reminder that learning how to do something like brief action planning is a little bit like learning how to swim. And so you might want to take yourself back to when you learned how to swim, and you probably practiced, and you didn't just learn from a book. You actually had to get in the pool, and you tried it, and you got some feedback. Maybe a sibling or a coach or a swimming teacher was there helping you learn how to kick your legs and move your arms. And you did that over and over and over again. So swimming became so natural that you really didn't think about how to swim anymore. You got in the pool and you knew where your arms went and how to move your legs and how to do that together. And so that's where you become so self-aware of your skills that you become unconsciously competent. You don't have to think about how to swim anymore. Your body just knows how to do that. So learning a skill like brief action planning is just like that. Looking at that flow chart may seem a little mechanical or a little difficult, but once you've practiced it over and over again and gotten some feedback, which is very important, it just becomes a natural way to have a conversation with somebody who's ready to make a change. When you're working with somebody who's not ready to make a change, we step up the care. That's where people might need a little bit more support, like in our step care model that we showed. The next slide is a little bit more about who is using brief action planning. Our nonprofit, CCMI, we work mostly with healthcare team members, so different healthcare professionals. We've trained doctors, nurses, nurse practitioners, pharmacists, physiotherapists, occupational therapists, social workers, oh gosh, almost every kind of healthcare professional imaginable. We've trained peer coaches. We've trained people with spinal cord injury who work as peers with other folks. We've also trained managers in brief action planning, and they use brief action planning when working with employees. I mentioned that we've been training peers. Brief action planning is being used in some medical schools training, and brief action planning is also being used in several research studies. Brief action planning has been used in hypertension management, in a spinal cord injury study. Actually, there's another one just starting up in spinal cord injury. Brief action planning is also being used in a prevention clinical trial and 2 prevention clinical trials, so, and also in pediatric obesity. So several research studies happening right now with brief action planning. The next slide is just a little bit more. If you want to know more about brief action planning, you can actually download the flowchart that you saw and a guide, which is more of a written out version. There's also brief action planning available in French, in Spanish, and in Chinese and Punjabi on the website. And now it's time for questions.
Okay, great. Thank you very much for that. Let's see. So far I've got someone asking from the perspective of a patient or client, somebody who's going to a health professional for care, that they understand the CAPE piece of it, but wondering about at what level it gets talked about on a respect level, because they often perceive condescension from professionals.
Oh, yeah. Oh, that's really a good question. And so to me, the respect is really in 2 parts of the CAPE. So in the acceptance, that's acceptance of people's autonomy, so people's right to make decisions. And healthcare professionals often can be very judgmental instead of understanding that that is the person's right. And the acceptance is also of accurate empathy. So being able to kind of put yourself in another's shoes and understand the dilemmas that people face. And then especially to me, the respect is in partnership. I mean, working together, respect is so crucial. And I'm so sorry that the person has experienced a lack of respect in their relationships, but to me that's crucial for being able to work together.
All right. And then someone else asked, towards healthcare members in brief action planning, do you have a recreation therapist on staff?
We do not have a recreation therapist on staff, but we have taught recreation therapists about brief action planning, so I could see where it would be very applicable in that field as well. We're starting to track all the different kinds of professionals that we work with, and it's pretty much a basic helping skill. And so we haven't found anybody who's not able to use it.
All right. And how do you reconcile the need for flexibility during MI with the BAP script/algorithm?
Yeah, so that's a super good question. I'm so glad you brought that up. And so one of the things that we really do know about brief action planning is we designed it so that when you're learning it, if you follow the flowchart as you're a beginner, so it's kind of a novice to expert phenomenon, the spirit of motivational interviewing is kind of built in for you. And so if you remember to do the steps like asking for permission, asking for their own ideas, that if you will start to learn those things as you learn it, then when you start to find your own words and your own approach, you won't forget those key steps. So what most people do when they're learning is they learn the kind of structured approach, and as they become more and more familiar, then they're able to apply the principles more and rely less on the script. Yeah.
Very good. And do you think asking patients how ready are you to change or how willing are you is important from an evaluation point of view?
Oh, yeah. So readiness to change is really interesting. And so that's something that was popularized by Prochaska and DiClemente with their stages of change, or the trans-theoretical model. And I think it's been a very valuable idea to help healthcare professionals just remember that people's readiness varies. And there's several interesting things about the trans-theoretical model, or the stages of change approach. So readiness to change, really, if you tease it out, it seems to be determined by 2 things, and they're importance, how important something is to somebody. So the more important it is, the more likely they are to be ready to change, and how confident they are that they can actually make a change. And the literature seems to support that what you do for increasing importance and what you do for increasing confidence are 2 different things. So asking about readiness is probably not as helpful as actually asking about importance and confidence separately. And so importance in brief action planning is kind of captured in question 1. Is there anything you've been thinking about changing in the next week or two? That, if you ask it that way, it's hopefully something that's on their mind, not that they haven't been thinking about. So its importance is kind of implied there. There are other things in motivational interviewing you can use to understand importance better. And the confidence question, of course, is in the rating people's confidence. The other thing I think that's interesting about the trans-theoretical model is it grew out of smoking cessation literature, and a lot of the evidence in the trans-theoretical model is built of stopping a behavior, and stopping a single behavior and a behavior that's addictive, so nicotine. In chronic condition self-management, we're often helping people start behaviors, and not just one, but many. And so then you have all of these different things to think about. So the readiness to change can be a little more complicated if you think about it that way. So I actually find it more helpful to think about importance and confidence. And in motivational interviewing, there's another way we talk about change and change talk and how strong the change talk is, which is actually listening to the person you're working with and thinking about change from what they're telling you, as opposed to thinking about it on a continuum. So maybe that's something we can talk about some more in the future, but yeah. So readiness is an important notion, but think about importance and confidence to help you know what to do to help somebody with their readiness.
I've got a couple of questions that relate to people who are very difficult on this level, like very resistant to changing or to doing the activities that are being discussed, and just people wondering what the hope, like, is there hope for people who, I mean, they do choose to not want to take these steps?
Yes, yes. So that's also a very good question, and often as clinicians, the people who stick it on our minds are the people who are the most challenging to deal with and whose behavior often we find puzzling. It seems clear to us that what they're doing is not going to lead them down a path that they say they want to go on, and so that's very troubling for us as healthcare professionals. And so just right off the bat, just to remind you that brief action planning is part of a step care approach. So with people who are very complex, one way you can try to use brief action planning that has been successful is to break it down really, really smaller. Instead of having it be the next week, have it be the next day, or have it be the next hour even. So if they're one little tiny thing, somebody who's really challenged can break down into what they can do. So that's one way you can use brief action planning. Sometimes it works, sometimes it doesn't. Another thing to remember is that those folks are the folks who need the skills farther up on the step care self-management support approach. So those are the people that are going to benefit from things like more motivational interviewing. There's lots of approaches in motivational interviewing, which was actually designed to address people's ambivalence and has lots of ways to address people who we interpret as being resistant to change. They may be somebody who would benefit from problem-solving therapy, a really excellent way of helping people take their problems and break them down into steps that can be worked on. That's a great approach that has been redesigned to be used by primary care providers. They might be people who need care management, and then of course the care managers need to know those more sophisticated skills to help people break down their problems into more manageable steps. So I guess what I'm saying is those people need more advanced skills, and we probably don't have time to talk about them today, but the motivational interviewing literature, the problem-solving literature, lots of ways help us do that. For brief action planning, just take it and see if you can find something tiny and small that's something they want to do, because remember, it's about building confidence. Very brief story. I worked with a lady once, lots of issues, lots of things. First action plan she made was about taking a bubble bath. And, you know, I may not see that there's a link to her health care there, but the important thing to remember was about building her confidence that she could actually make a change in her life. Her second action plan, after she was successful in having a bubble bath, was to call an old friend and reconnect. She was successful doing that. Her next action plan was about taking a walk. And so for her, it was about building her confidence that she could actually make changes in her life that led her to make changes that were really helpful for her health.
I think that's a really good example, because sometimes it is the things that seem unrelated that can be enough of, like you said, just focusing on building the confidence itself. And then maybe one more question. Someone was asking about regarding checking in, skill number 5, and if the person has done about half of his or her plan, should obstacles be explored and skills 2 through 4 be covered again?
Yes, that's a very good question. And when you go to the website and download the Brief Action Planning Flowchart, you will see that there is a nice little flowchart there to help you with the checking in. And so you've hit on a really good point. If people are successful, the approach is just, great job, what do you want to do next? Most people want to continue their plan or add to their plan. If people are partially successful, most people are going to be kind of down on themselves. And so the approach then is to affirm what they have accomplished. We don't get enough positive feedback on our lives, so wow, you did it once. That was a really good start. You actually did it. What do you want to do next? We actually recommend asking a really open-ended question, remembering to elicit there, and then if people say, I'd really like to figure out how to make that work, then you go into problem-solving mode. I think the literature tells us that if we bring up problems that people haven't brought up, then we can actually decrease their self-efficacy. So we're going to help our people, help the person we're working with when they tell us they're ready to help. And then you have your behavioral menu. If they don't have ideas on their own, then we use the behavioral menu as a problem-solving approach. So yes, very good connection back to that. And then just a word to the wise for people who are unsuccessful on action plans more than once. You might not want to use action planning. There's a little hint from one research study that can actually decrease self-efficacy. Just like every approach doesn't work for everybody, action planning is not for everybody. So don't persist if it's not working.
Very good. I think that's very helpful as well. All right, I think we'll go ahead and end. Thank you very much, Connie, for your presentation. I think it was wonderful.